Welcome to the Movement Prescription Podcast. I'm Callum Lees, I'm your host for today, and today I've got with me Dr John Sykes, who's a GP in Bath and a lifestyle medic. He did his undergrad at Durham Uni, his medical degree at East Anglia, and as well as working in a GP in Bath, he somehow manages to combine being a fellow of the Australasian Lifestyle Medicine Society, and he's a trustee and director of the British Society of Lifestyle Medicine as well. I came across John at a recent conference back in September, and he was up on stage talking about resistance training and its impact on health. And I thought, what a cool topic for a conversation. So, John, thanks so much for joining and to explore that topic further.
No problem at all. Thanks for having me, Callum.
I basically wanted to start just by asking you a bit about your story and how did you get interested in lifestyle medicine and resistance training?
Yeah, of course. So I've kind of always been interested in being active myself. And for a long time, I was really keen on becoming a sports medic. So I really wanted to be a sports medicine doctor for kind of a football team, especially my teams. But I don't know, the more I went to conferences or information that I learned about sports medicine, the conference topics often had information around public health, and often that went on to how activity or exercise could be used as a form of, either treatment or modality of looking after long-term conditions. And the more I found I looked into this, the more interested I became, the more the evidence that I looked at, I realized how strong this evidence was, to the point where, you're looking at kind of medicines that we have for hypertension, diabetes, even other things like anxiety, depression, dementia, all these things. We've got a modality in being physically active, which is actually seems to have a stronger effect than any of these things for a lot of them. But not only that, of, kind of reducing the chances of those diseases, but also reducing the progression of those diseases or the complications of those diseases, and in some cases, even reversing them. So I think it kind of stemmed from there. From there, I was doing my GP training, again, still with the intention of doing sports medicine, but I found that I was getting myself more involved with different conferences, different groups who were pushing this lifestyle medicine message, got more interested in nutrition aspects of things, sleep, kind of stress management and those things. And then it kind of stemmed from there, really. I was lucky enough to go to Australia for a few years, where I got involved with the Australasian Society, set up a clinic out there for doing lifestyle medicine. But I would say my main passion throughout all of this has always been being active, probably stemming from the fact that I enjoy being active myself. I see the benefits in myself in my day-to-day. And being a keen footballer, over time that developed into doing more resistance training. And in fact, I found that resistance training was an avenue for me to gain benefit in a way that I probably wouldn't get from cardiovascular exercise. And again, the evidence does seem to suggest a huge, huge benefit from that. And it's now something that I try to, when appropriate, recommend to patients, just because of how much benefit we see.
Yeah, that's super interesting. How did you end up as a trustee and director of BSLM?
Yeah, so essentially, it was a bit awkward, actually. I'm sure Rob Lawson will explain it as a bit awkward as well. So in my final year of being a GP trainee, I was going to organise a conference, and it was all going to be about physical activity. And a good colleague, friend of mine, said, "Oh, you know what? There's this new thing called lifestyle medicine that's developing. Maybe you should include aspects of like nutrition and stress management and call it a lifestyle medicine conference." I was like, "Yeah, it's a good idea. Let's do that." And then about 6 weeks before my conference, which I organised for Bristol, I get a call from Rob Lawson, who asks me, what you're doing a conference on lifestyle medicine, as I find out that he was starting BSLM, the British Society of Lifestyle Medicine. Their first lifestyle medicine conference was the week before mine in the same building in Bristol. So it all worked out in the end. He came to my conference. I went to his, and actually both were fully attended, and actually, if anything, showed how much of a desire and will there was to get involved with lifestyle medicine. And my enthusiasm kind of stemmed from there, and Rob and I were kind of, keen to connect off the back of that. So that's where that kind of came from.
Gosh, that's amazing.
As I said, started off being a bit uncomfortable, a bit awkward, that I'd maybe stepped on a few toes, but actually it was totally innocent, and it led to a really good outcome in terms of getting involved with BSLM, who, as I said, I'm lucky enough to be involved with them because I've been going from strength to strength from then, which has been fantastic.
isn't it super cool when you end up meeting people that are doing very similar things or the same thing as you, and you can kind of combine forces, and momentum takes you in amazing places, doesn't it?
Totally.
Well, look, John, one of the reasons I want to bring you on was to discuss resistance training and the growing evidence for the importance of resistance training and functional training. But really, what does that look like for people working in primary care? How can we practically implement that? And so I wanted to first of all discuss some of the barriers. And I know that there was a recent paper, and we'd emailed about it by Garcia and Hermoso, which talks about only 17% of adults in the world, and it's only about 14% in the UK meet the guidelines for physical activity when you include the 2 times a week strength training that is in the guidelines. And so I wondered why you think so few people do resistance training.
Yeah, so I think there's a number of reasons. The data that you've said there is quite interesting. It certainly shows lower numbers than what's reported elsewhere. But again, it depends where you look. So, in some places, it seems to report that the amount of people in the general population hitting the physical activity guidelines is close to kind of 40, 50% for men and women. And this paper's obviously saying less. In fact, when they do accelerometer data, which isn't self-reported data, it seems to be even less again. So even though we think we might be hitting, the moderate level of activity in the week, then it's even less. And in fact, one paper showed that of people who think that they're hitting the activity guidelines, only 1% are actually properly hitting the guidelines. So, that was a select group of people, but it just shows, unfortunately, how little activity I think that we do a lot of the time. In terms of barriers, I think there's 2 aspects of looking at this. If we look at kind of activity in general, and I use that word intentionally, I think people don't like that word exercise. I think exercise gives the impression of being uncomfortable, being out of breath, being in a situation that brings, to a certain extent, an element of distress, an element of not being in a place that individual wants to be in. So I think using the word or the term activity as opposed to exercise, even when we're thinking about resistance training, using activity can actually make it feel like a more approachable thing for us to do. It's not seen as something which is intimidating as much when we're looking at kind of activity.
I think it's a really interesting point. There's a book called Exercise by Daniel Lieberman. I'm not sure if you've read it, but it has a it's really interesting for listeners. As basically his premise of the book is, as a noun, exercised can mean exhausted or burnt out, and therefore there's negative connotations with that word, and talking around a whole psychological reframing. So I think vocabulary is super important here, isn't it?
So I think that's one of the reasons for the barrier. I think the second aspect, if we're looking specifically at resistance training, is multiple. So I think there is a real intimidation factor around gyms. I think there is a barrier to access in terms of affordability. Gyms are expensive. I think there's a barrier to access in terms of even knowledge. In order to do a workout, a strength-based workout, you need to have a relative amount of knowledge, not just of what you're doing, of what sets are, of what reps are, of how you're meant to lift the weight, technique. Then there comes into it, well, I don't want to go to a place where I'll be watched. There's this element of, people will go to the gym and they'll think I look silly. And then there's the fear of harming oneself, actually causing harm by doing an exercise in a wrong manner, or doing something which could actually be negative. For, say, someone who has a background heart condition, they don't want to push themselves in a way which is too much. So I think there are multiple barriers, and I think that really needs to be considered when we're looking at resistance training and making sure that we try and make it as accessible as possible. It's why exercise referral schemes and other things put in place, like certain resources, which I'm sure we'll go on to talk about, are so useful. But I think one of the things which, as practitioners and generally as a community, we need to be doing is normalizing resistance training, whether it would be in those who are of a younger age, of middle age, or of those of an elder age, because, as I said, the benefits we see throughout all of life, it can make a huge difference to quality of life in all those age categories.
I think that's a really interesting point. And I think there's a misconception that resistance training equals weightlifting. And I think that needs to probably be debunked as well. We had a really interesting experience recently where I'm kind of involved with an organization locally called Healthiest Town, and we had a market stall at the local market, and in the middle of the day we did a chair-based exercise class, and it was really interesting to see people's reaction to that. I think at times it was negative from certain groups, but actually I think it was a real eye-opener to a lot of people about what is possible to all ages and demographics with regard to resistance training and what can be done. Even if you can't get out of the house or can only walk 150 meters because of knee pain or breathlessness, there's still things that you can do.
And just to draw on that, I mean, another, I think, barrier is the way, because you're kind of talking about perceptions there of resistance training. I think it's the perception of what the goal is. So often when an individual in a clinic will say to me, I want to become active, so let's just focus on cardiovascular exercise for now. Someone will say, I know I need to lose a little bit of weight. I'm going to start becoming active. It seems like the automatic way of losing weight would be to become more active. Now, if we think about it in resistance training, people maybe think of their goal as getting really muscly and really big and, showing off a physique of some kind, when actually that shouldn't be the goal either. So making these goals around weight loss for, say, cardiovascular exercise or for resistance training or for body goals in a certain way when we're talking about specifically resistance exercise, I think actually should be something which should also shift to looking more at the benefits from a health perspective, which is what we see amongst multiple health conditions. And the great thing is we know these things are happening. We know even if someone's doing a small level of activity or of resistance training or cardiovascular exercise, they are getting those benefits. So we don't need to assess weight. We know regardless of weight, these advantages will be happening. We don't need someone to look like, Zac Efron in order to get the benefits of resistance training. They'll get the benefits because they're doing it. And I think that needs to be a real shift in mentality in the way we perceive the actual goal of whatever activity we're doing.
Yeah, I really like that comment you made about weight and shifting away from exercise predominantly as a form of weight management. Because I don't know if you've read Chris Van Tuliken's book recently, Ultra Processed People. He's a chapter on why exercise has a limited effect on weight reduction. And I think it's a really helpful thing to debunk that we should be encouraging people to exercise for the plethora of different reasons and benefits that it has, as opposed to just weight loss. And because I worry that if we sell it for people that are trying to lose weight and they don't lose weight, then they are alienated from exercise. And there's so many different benefits that it offers.
Exactly. And they'll think that it's failed. They'll think that the intervention of the activity has failed, even when it hasn't. If their goal of what they should be achieving through activity is weight loss, when they're not going to achieve that, they will think that they're failed. When actually, if they know that they're going to get the benefits through all the bodily processes which are going on, which you can't really measure a lot of the time, then we've got to see that as an encouragement.
Interesting. This is a bit of a kind of a left-wing question that I didn't prep you for. I've done a bit of work recently, some research looking at stigmatizing environments for exercise and how often healthcare settings for exercise classes people deem as stigmatizing. But I think you mentioned it, the intimidation around gyms can be stigmatizing as well. And do you think, or what do you think is a location which we can deliver resistance training which is less stigmatizing?
Yeah, I think it's hard. I don't think it's a simple, one fit model for the individual. And I think whenever we discuss lifestyle mental interventions, we always talk about an individualized approach being core to any intervention that we consider. For example, if we look at, say, someone who comes to me who's been in a gym before and feels relatively comfortable, my intervention or my recommendation to them from a resistance training point of view is going to be very different to an individual who's never been in a gym before who finds that very intimidating. So where we deliver it, I think, is dependent on the individual. So, for example, if we talk about that second person I just talked about, we'd probably be thinking about some home exercises initially until that individual becomes a bit more comfortable with doing some resistance training, feel comfortable with the fact they're doing the technique right, and actually they've managed to build up a bit of endurance in terms of doing that activity. then that might progress to, for example, going on an exercise referral scheme or doing a group class, for example. That then may progress to going to a gym for the first time or trialing a gym for a period, or maybe even getting a personal trainer, even if it's just for a short period. Again, we don't want to talk about making other barriers to entry in terms of personal trainers, although personal trainers are very affordable in most of the cases, not for everyone. So if we're able to kind of gradually introduce those things, what could be a good starting environment for an individual with doing some activity, some resistance training, could end up being actually, developing into them actually being very comfortable in the gym. And it's all a bit of a learning process when we do come into resistance training. I know as a personal kind of experience, I found that was quite a big one. I went from being someone who didn't have a clue what he was doing to over time actually relatively did. And, some people will engage with that process more or less. But as I said, it comes back down to the individual and what they feel comfortable. Initially, for me, I felt pretty uncomfortable in the gym, but comfortable enough to give it a go. For others, that may not be the case. And for those, we need to tailor practices to them to make them find a way of them feeling comfortable doing those exercises. And that could be, as you talked about, in a gym, or it could be at home. It really depends on that person.
There's an article by Edwards and colleagues published in July about the best exercises to lower blood pressure. Isometric resistance training came out top. Basically, I think the take home from it is all forms of exercise are really good, but resistance training in some form is best for lowering blood pressure. And I just wanted to see what your thoughts were on why you think resistance training is so good for us, and why in some capacity it's better than traditional aerobic. I know that there's a role for both, but why do you think it's so good for us?
Yeah, I think it varies depending on the stimulus, and it depends on kind of what age category we're looking at as well. I mean, if we're looking at, say, elderly population, there seems to be really a strong amount of evidence that there are molecular mechanisms working when we resistance train, which will reduce the effects of things like sarcopenia, as well as diapenia, which is the actual loss of power that we get from muscle. So sarcopenia is the loss of muscle mass. Diapenia is the actual loss of muscle strength. And there are processes when we resistance train which actually stop those things happening. Now, if we're looking at from a risk point of view with someone who is elderly, we're thinking about falls, we're thinking about osteoporosis, the risk that can come with fractures, and then obviously loss of mobility, loss of independence that accompanies that. So if we are getting someone who is able to resistance train in their older years, then they are not going to be at risk of those same things. So we're not going to get that loss of independence. We're not going to get that kind of increased risk of falls or fractures and similar types of things like that. Instead, we're going to get someone who probably has got increased functionality, increased ability to do things going forward. So if we then, again, concentrating on the elderly population, we then switch lanes to thinking about memory and how important that is. We know there are multiple molecular mechanisms involved with being physically active, but more particularly if we focus directly on resistance training that actually seem to play a role. So, for example, we know that there's less of a cognitive impairment generally. We know this is partly due to reduced atherosclerosis, which is due to the way in which resistance training will actually reverse that or stop that happening. We also know that resistance training combats kind of inflammation levels. So there's chronic inflammation levels that we know can lead to other issues which can lead to cognitive impairment like amyloid deposition in the brain. And we also know it can reduce the risk of kind of decrease of certain growth factors, insulin like growth factor, brain-derived neurotrophic factor, these important factors for cognitive availability and neuroplasticity. So if we are able to stop those processes getting worse as well, we're going to have a healthier individual. So there's the molecular side to it, which can happen in different stages of life, and the importance of that is very much seen across all forms of exercise, and we see these effects all form and all those kind of different effects of exercise. But we do seem to see it particularly strongly with resistance training. You mentioned the study about the isometric training. It's really interesting, the isometric training. So if we think about kind of isometric training, this is something which I've not used an awful lot of, if I'm totally honest. But if we think about kind of a movement of, say, lifting a dumbbell to a bicep curl, everyone knows that movement. Unfortunately, that's the vain movement of someone who goes to the gym. But if we just think about that movement, if you've got the dumbbell down by your side and then you pick it up to kind of pulling that weight towards you and then up to your shoulder, that's the concentric movement, which is a shortening of the muscle. And then if we then lower that weight down to the lower level, that's the eccentric movement. If we hold the muscle halfway, the weight halfway, that's the kind of keeping that weight in place. That's the isometric hold. So there are a number of different isometric exercises where we're keeping the muscle in the same position, but the muscle is working. So we think about extreme isometrics, like keeping in a lunge position or a squat position, a deep squat, or we can think about maybe doing a wall sit. These kind of exercises are thought to be very efficient, quite demanding on the body, but actually in a lot of situations quite doable and in fact quite low risk in terms of injury as well. So this study particularly, as you've said, seemed to show that those were the best ones for blood pressure. I think whenever we think about the best exercise, I think for me, it's always about going back to that individual approach and what that individual feels that they're able to do. I think if you've got someone who really enjoys doing a range of different type of resistance exercises, which are more focused on power and strength, I'd say go for doing that. You know, if someone is able to keep up consistency with that workout or that type of activity, regardless of kind of what it is, that would be the thing that I'd be encouraging. So you're right. There are loads more studies now looking at different forms of activity, high intensity interval training, isometric exercises, all this kind of fancy, clever stuff. But for me, it's always about what an individual enjoys doing, it feels that they can do for a long period of time. And actually, that's the thing that's going to get that individual the more benefit.
Oh, great. Well, in fact, what a great explanation of concentric, eccentric, and isometric as well. And I totally agree that the isometric feels low risk, doesn't it? But we've got to cater towards individuals. And I was actually watching what inspired my interest in lifestyle medicine initially 4 years ago now, was reading Blue Zones by Dan Buettner, which is this great book about the 5 places in the world with the highest percentage of centenarians. And it's actually just been released on Netflix as a documentary. I'm not sure if you've watched it, John, but I was watching.
Yeah, I've seen that. I haven't watched it yet, but it looks good.
Yeah, it's worth watching. It's great. And I was watching it last night, and the episode on Sardinia, and basically they talked about these villages in Sardinia that are built into the hills. And what they found is that despite neighboring villages or villages down the hill having very similar diets, that people lived longer in these villages built into the hillside. And that it was in part because when they're walking, they have to walk up and downhill all the time. And they've usually got up to 4 flights of stairs in the house. And so even just walking up and down a flight of stairs is resistance training in a super simple form. But it was just really interesting, that necessitating resistance training into day-to-day life. And I've often wondered, and I would love to do a research study at some point on this, but we often encourage our older people, and certainly my grandparents, they moved out of a house with stairs into a bungalow when they're in their 70s. And I wonder if we're doing them a disservice, because by not having stairs in the house, they defunction, their legs get less strong. They're not doing the day-to-day up and down the stairs that they would otherwise be doing. And as a consequence, are we failing them? It's a really interesting thought, because obviously there's risk in having stairs and falling down. But yeah, I really enjoyed that episode, and yeah, give it a listen, give it a watch, and I'd really encourage anyone else to give it a watch as well.
But you make a really good point there, Callum, in terms of, you know, us maybe doing people a disservice. And I think that actually comes through a lot when we talk about resistance training. I know me personally, I often felt quite nervous to encourage people to resistance train, because I was worried about them having an injury. I was worried about them finding it non-enjoyable or being intimidated by those gym factors which we've already discussed. But actually, when we're thinking about it, the benefits that you can get from it are so great that they are things that we should be encouraging. They are things that we should be promoting and trying to make more accessible, because the benefit that you get is just so, unmeasurable in terms of outcomes. So I think you're right. In terms of being in a bungalow, there are negative connotations of that as well. But generally with the resistance training, I think sometimes we can underplay its importance and sometimes be worried about the risk when actually we maybe should be promoting it more than we are.
I think that kind of moves us on nicely to what I wanted to talk about next, is that we have an advocacy role in the normalization of resistance training as primary care practitioners. But what might it look like for us to recommend it in primary care? And I maybe wanted to start with just getting you to talk us through what a resistance session might look like, for example, a 30-year-old male with a BMI of 29. And what would you possibly advise them to do regarding resistance training?
So I think it's all about finding out where they're at the moment, if they've done this kind of stuff before, and what they've got access to going forward. So, for example, with that 29-year-old, what's their current situation? Have they been in gyms before? Do they feel comfortable in gyms? And do they have access going forward? And then just getting an idea of their understanding of, what resistance training could even look like. Do they understand what sets mean? Do they understand how many repetitions we should be looking at? Now, sometimes that can involve, having a little chat about that and saying, well, look, you probably want to be aiming to do 1 to 3 exercises per week on each body part, which would be your chest, back, legs, arms, and maybe shoulders as well. Doing that once or twice a week, building that up over time, aiming for kind of doing 3 sets at a time and aiming to do 6 to 15 repetitions in each of those sets, making sure that the last few repetitions in those sets are quite hard work. And obviously trying to ensure that what they're doing is safe. So in some situations, and this hasn't always happened, and obviously time limitations in general practice make this pretty difficult sometimes, but on the rare occasion for an individual who's particularly worried about doing resistance training, I asked them to video parts of their workout, the exercises they were worried about doing, so that we could then discuss the form when they came back to see me. And again, it wasn't a very big part of my consultation, so it didn't take up loads of time, but he was able to show me his squat form, which actually was very good. And it then gave him the reassurance to then pursue other aspects of working out. And then again, just kind of explaining that the way you're going to see the benefit is progression over time. So increasing that resistance over time. Don't going too quick, too hard. It's not about vanity lifting and lifting really heavy stuff, but it is about trying to push yourself over time and trying to see that progression. So that's probably what I'd aim towards a 29-year-old. I mean, for say someone who's a bit elderly, I think I'd probably direct them to resources such as the NHS website, which has got some fantastic resources on strength and conditioning. They talk you through some videos. There's even some chair exercises, which sometimes that stuff is by far the best stuff we can be advocating for, and actually often the safest way of doing it as well. So anything like that can sometimes be an easier way of giving information to someone, because, we are lacking time in general practice. So to go through all the exercises in form and things would be difficult. And I often rely on YouTube as well. I think YouTube's got some fantastic resources in terms of videos for, you just have to type in chair-based exercises into YouTube and you'll have a whole list of good videos which can talk you through anything from a 3-minute workout to a 20-minute workout. My wife's dad does YouTube exercises every single day. He's 93 now. He's always been a bit of a creature of habit, but he absolutely swears by them. They're done by an American group. It's all a bit cheesy, but it's really good. And, there's no doubt the reason he's still a very functional 93-year-old partly is due to his ability to want to keep doing those videos and keep them up twice a day. So using those resources can also be really helpful. I think whenever we can talk to or get patients to talk to professionals in this area, it's going to be useful, but there are limitations to that. But health trainers, health referral schemes, social prescribers, anything like that can just be that extra level of support, but also accountability to help that individual to continue to pursue that. But as I said, it does vary where you are, how available those things are.
I think you have some really great points there. And resources are such an important thing, aren't they? Particularly when we're limited for time. And I was going to ask you how we, in limited time, how we realistically bring up resistance training into our consultations. But signposting is one of the easiest ways to do that, I think. And the NHS website is great. And I'll put a link in the show notes. Age UK have got some really good resources as well. And yeah, YouTube, you can often drown in volume, can't you? Which is challenging. And I know Joe Wicks did some really great stuff over COVID, and there's some brilliant material out there. But signposting's brilliant. And I don't know if you have we've got the local kind of council run fitness centers have a referral scheme, and the personal trainers from there can deliver sessions for patients that have health issues that are deemed in need of referral from doctors and nurses, which is a really great service that we have. And it might be that you have that locally, John. I don't know, but hopefully some other people have it as well, because I use that quite frequently. I suppose, my last question, John, for you is, what are the priorities, or what do you think the priorities for the last 60 seconds at the end of our consultation that we should try and get across to patients regarding resistance training are? What's the message that we should be selling? And if you'd be willing, how you would sell that in your consultations?
Of course. So I'd be stressing the importance of how much benefit they give to people. That, resistance training is not just for the person who wants to look good and gain loads of muscle and get big. Like that's not the intention of doing so. So it would be how important it is and how this individual can go away and do this safely. Whether that would be following the NHS website instructions, as we've just talked about, following a Joe Wicks workout, as we've also discussed, doing so with a level that they feel comfortable doing, they feel safe doing, and they feel that they can then kind of come back to me in a few weeks' time when we're discussing maybe a totally different issue, but they can comment on a way in which that they want to progress from there or develop that skill further. It would be making sure that they see their benefits and also making sure they're going to do so safely, or as safe as possible.
Brilliant. Do you ever counsel on DOMs? Because I think sometimes people talk to me about pain of exercise, and I sometimes find it hard to find the right words to communicate what is an okay pain and what isn't. And particularly in resistance training, that people probably will experience some delayed onset muscle soreness in the 24, or I often find 48 hours following training, it's worse. Do you communicate that? And how do you do it if you do?
So it does depend on the individual a little bit. I think the last thing I want to be doing is giving another barrier to potentially trying this. But at the same time, you're totally right. You don't want to be kind of leading someone down a track where they're going to get something they're not really expecting. I think I'll say for any activity that we do, which is new for the body, you might find the body's a little bit sore for a few days. If you're worried about the soreness, feel free to come back to me and we can have a chat. But it's rare that soreness is enough to stop you doing things. And to be really honest, I mean, in most cases, I'd hope that they're not pushing themselves to horrible DOMs where you're struggling to get up the stairs or anything like that. But yeah, I think maybe making a note of the fact that you can experience some delayed onset muscle fatigue or soreness is worth mentioning. But again, it's about that individual and making sure that you're not putting up that further barrier to potentially giving it a go.
Oh, John, that's brilliant and great advice. And as ever, it's trying to tailor what we have to our patients, and it's the joy of primary care is catering for individuals. I don't know if you got any final thoughts, but I just really want to thank you so much for joining us today and sharing your thoughts. And I've learned a few bits and pieces, and I'm sure listeners will have as well. So yeah, thank you so much.
All right, thanks for having me.
Pleasure. Enjoyed listening to John as much as I did. A couple of things that struck me from that podcast were the importance of language and scene setting as well. Often When we talk about resistance or strength training, people are intimidated because they have these visions of kind of rust-filled, testosterone-fueled gyms. And that's really not what we're talking about. And often strength training can be limited by our lack of imagination. Maybe it's just lifting sandbags, doing a bit of gardening, walking upstairs, or going for a walk with a weighted bag. Our job as health professionals is trying to find what people enjoy and allow them to utilize that. There's loads of resources out there and almost too many. And we touched on that in the podcast. It's so easy to get lost. We'll share some links that we find helpful in the show notes, and I hope you do too. And we'd really love to hear from you. So if there's anything that you think is great, please let us know and we can add it in and put it on our website. And the final thing we mentioned is pain. Delayed muscle onset, but also pain during exercise. There's an interesting statement that I found afterwards from FSM, the Faculty of Sport and Exercise Medicine, and it says this: expect some discomfort after your workouts, but you should not be in pain. If pain more than 2 hours after exercise is worse than it was before, reduce the length and or intensity of the next session. And DOMS is usually worse, as we mentioned, in 24 to 48 hours after exercise. Hope you enjoyed listening. Please share some thoughts. And if you enjoy the podcast, share it with other people that you think might enjoy it as well. Thank you.